As a paralytic, particularly long-acting paralytics. Because it's really nice for the neurosurgeon to know that the guy was moving all four before you paralyzed him for 50 minutes. Treat hypotension. Now, this is all concurrent. This is because it's a team game here. If the patient's hypotense, while you're doing this stuff, they're going to need some fluids. They may need epi-drip. I'm not doing push dose. I still like the epi-drip thing because you know how to do it. It works well. It's our go-to thing for, even in the ED, most of the time when we have a really hypertensive patient, they're using an epi-drip. Ultimately, you may go to a norepinephrine drip. Position patient with ear at the level of sternal notch, face parallel to the ceiling, looking at the ceiling, if you will, and then elevate head of gurney to 15 degrees. That's your ideal position. Now, that, I know you don't do it often, but we may want to practice that. It also helps to have the gurney elevated to a position where you're over the patient this way. You're not crawling on the floor. Almost never in the ED will you see the ED docs put the patient on the floor so they can intubate. Now, monitoring equipment, no change, but we just cleaned it up, made it a little nicer. So pulse oximetry, cardiac monitor, et cetera, but suction, BVN, and suction has to be the good, big volume suckers, not those, not the little things that don't work. BVM with a PEEP valve, CPAP. Have all that stuff available. ET tubes, bougies, surgical airway equipment, etc. And you're all set up and running. Now, pre-oxygenation. This would be standard, normal approach for the average patient. So standard RSI is you pre-oxygenate, breathe adequately. If they're breathing adequately, apply a non-rebreather mask at maximum flow rate, or your choice. If you think it's congestive failure, or if you think it's COPD, even asthma, a CPAP. Some people do better with a CPAP, some people don't. Apply the CPAP, and you're looking for a target O2 sat of greater than 94%, greater or equal. And then, it's nice to set a stopwatch. Then, ideally, you let 3 minutes of 94 or better elapse. So they're breathing high flow O2, they're breathing it well, and what you want to do, what you're doing in that 3-minute period is denitrogenating the patient's lung. Air, normal room air, is 21% oxygen, the rest is nitrogen, and a little bit of CO2, but mostly nitrogen. If you wash out the nitrogen and replace it all with 100%, that's what we used to say, filling up the residual capacity. You're washing the nitrogen, replacing it with oxygen. You're buying that patient a long time with good oxygen available. Then you can proceed to RSI. If the patient's not breathing adequately, if they're having trouble breathing, then put a BVM on, 25 liters per minute, with an NPA or an OPA, 2-person BVM control, you get a good seal, and then get them up to 94%, and you can do And then after three minutes of that, if you if you have them nicely washed out, proceed to your RSI. Now, you say, well, wait a minute, I'm waiting a long time, 3 minutes? Wait a minute. I already showed you that last one. We went for 9 minutes between the time they had an adequate O2 sat and the time they got paralysis. That's perfect. You don't need to go that long. You get it done in 3 minutes. Now, if unable to achieve an SpO2 of 94%, go to the DSI procedure. So tuck this one away. Just keep it there, because we do have it set up as a flow sheet to make it look better. Now, your standard RSI procedure, nasal cannula at 15 liters per minute. Once the paralytic is pushed, then you get apneic oxygenation. Remember, they have adequate oxygen already, but you'll get a flow of, unless there's an obstruction, you get a flow of oxygen downhill into the lower concentration. Apply jaw thrust unless you've got an NPA or OPA in. No cricoid pressure recommended. You can use extralaryngeal manipulation technique. Prepare for continuous suction as needed. Then, if you use succinyl choline, you're waiting for fasciculations to stop or 30 seconds. If you're using rock uronium, and rock could be chosen if you had a reason for it. Maybe you think the patient's hyperkalemic, maybe you think they've got a history of myasthenia or some of the neurologic things. With rock uronium, you have to wait 60 seconds. You won't get fasciculations ever with rock uronium because it's not a depolarizing drug. It's a non-depolarizer. If with your drugs, either your drugs, you don't have relaxation adequate in 90 seconds, then make sure your O2 sat is your nasal cannula is running. Make sure that you have a patent IV or IO. Repeat the dose of paralytic. My experience, the usual reason it doesn't work is you miscalculated the dose in the hurry. So you can repeat the correct dose of succinyl choline, which is 1.5 milligram per kilo, and if you use rock uronium, you can use half the dose, so 0.5 milligram per kilo. Then visualize the epiglottis and intubate. After intubation, we do, now, I'm going to give you unsuccessful intubation. I'm going to arbitrarily call 2 attempts. At that point, insert an SGA and ventilate, or if it's a trauma case and you should have already made up your mind before that to do a cricothyrotomy. Or occasionally a severe allergic reaction. If the patient becomes bradycardic, halt intubation, ventilate with VVM, with PEEP, and then give atropine as needed, if you needed it. You don't have to routine. Atropine won't cure it if they're hypoxic. Upon successful intubation, same thing, capnography as usual capnography. We haven't changed that protocol at all. And we haven't changed the protocol if the waveform is deteriorating or you lose it. Troubleshoot very quickly, but if there's any question, pull it. Almost always we have, and pull it into place, because almost always we have a problem with an esophageal intubation and not with the equipment. Post-intubation, fentanyl is our first drug to go to for post-intubation pain and sedation, and then you can add midazolam. I've taken ketamine out of post-intubation just because it's just one more thing to confuse you on, why have to make a choice that the emergency department and the hospital are using either fentanyl and midazolam for sedation. We'll just keep it the same way. You can use all the ketamine you want for intubation. And we're going to now go to that in a minute. Ventilation rates are no change. Now, delayed sequence. So, remember, you've got back here, you're pre-oxygenating the patient and you can't get them up to 94%. They're still staying in the, or they're fighting you, or okay. Now, you may, right off the bat, decide that say, I need to RSI this patient, but I think because their O2 sats 85 and they're agitated, they're fighting me, they're not allowing me to put a CPAP on them, I need to get control of this scene. So if O2 sats are still less than 94% after pre-oxygenated because they're agitated, hypoxic, hypercarbic patient, they won't tolerate conventional pre-oxygenation attempts, go to the DSI procedure, but just start out with a sedative, with ketamine only, not with etomidate. I think etomidate is fine, but I like ketamine. Etomidate is not fine, it doesn't work for the DSI procedure. Because the advantage of ketamine is you should always think ketamine when you're dealing with primary respiratory issue, because not only does it sedate you and provide amnesis, but it also improves ventilation and breathing in most cases. Now, if you give it fast, you can get laryngospasm and some chest rigidity sometimes. But we're going to go with DSI, start out with ketamine, 2 milligrams per, so the intubating dose, correct? The sedating intubating dose, 2 milligrams per kilo, with a max of 200, we're just saying you should not be more than 100 kilos. 2 milligrams per kilo, given over a minute, no faster than a minute. In fact, if you want to give it over 2 minutes, that's even better. Just a slow sedation, and the patient will begin, at a certain point, they'll get less agitated, less fighty. You still have to have, and then you'll be able to put your mask or your CPAP on, and then continue to the full intubating dose per kilo. Then, now that they're sedated, right, now that they're dissociated, still sedated, if they're breathing adequately, I would argue that you're probably going to not, in that case, if they're breathing, and sometimes with the ketamine, they will just relax and start breathing at a normal rate, and they're moving air relatively well. Then either put a CPAP on them, or you can apply the BBM, 2-person mask, high flow O2, 15 to 25 liters, and just let them breathe. Don't ventilate. Put a PEEP, have a PEEP on that, do it, and a PEEP should be set at 10, and let them, and if you can get their O2 sats up that way to 94, then you continue that for 3 minutes to get washout, denitrogenation. Then paralyze with your drug of choice and go to intubation. You don't have to add any more sedation. Don't add any more ketamine. Don't add any of the tums. You've already totally sedated the patient. As soon as you paralyze the patient, you can also put the nasal cannula on for apneic oxygenation while you're going through the intubation process. Now, if they were not breathing adequately, they're in the 79 range, they were fighting you, and they're just not, because of their asthma, because there's whatever COPD, they just were not functioning adequately, then you use a 2-person BVM and ventilate them with a PEEP and 100% and high flow O2. Do the same thing, try to get their O2 sats up. When you get their O2 sats up, then paralyze, go through your DSI procedure. If you're unable to achieve 94, greater than 94%, no matter what you're doing to the patient, drop an SGA and continue to ventilate them with 100% O2 through the SGA. Or, and you can use paralytic or not, because more than likely they'll be able to, unless they have some trismus of some reason, they probably will tolerate with 2 milligrams per kilo of ketamine, they'll probably tolerate the SGA quite well. So, but at any point in this game, just like this lady, if you cannot intubate the patient or their O2 sats are falling, if at any point you say, hey, I have to put an SGA, I have to get a definitive airway, no. The SGA isn't as effective in trauma because it won't protect your airway as much. It won't protect as much against vomiting, but they're going to die of hypoxia first. They're not going to die of their aspiration. So you need, it's no big deal to prevent aspiration if you've got a patient who goes into cardiac arrest because of hypoxia. So the SGA will save you all the time. Now, in a pit crew, in intubation in a cardiac, so we will be training in multi-scenarios to the DSI thing. And we'll make you make choices. And hopefully you will make all the right choices, because our scenarios, if you make the wrong choice, the patient will break you down. Now, they won't necessarily die. We never kill our scenario patients. Okay. Initial management of intubation and cardiac arrest. So, PIT group with an SGA, initial advanced airway. The majority of transporting the majority of patients transported in cardiac arrest or who have achieved ROSC may be managed with an SGA. The problem with intubating the patient is, as you know, sometimes there's a difficult intubation, and if someone's in a cardiac arrest and just has an ROSC and is, barely maintaining blood pressure, you don't want them to desat and brady out and then go into a cardiac arrest again. This kind of defeats our purpose. So, a decision to intubate may be made, though, due to further airway control and oxygenation. They may not, sometimes they are not adequately ventilated with the SGA. Rarely. I have to think, when I look at it, if it says 98% CO2 of 40 with an SGA in place, and the patient's not bucking in the tube and not having any issue with it, I really wonder what would be the advantage of spending a minute or two without adequate oxygenation in that patient. Now, don't interrupt CPR. If they have ROSC and you're going to transport the patient, a lot of times we said, hey, if they aren't waking up after their ROSC, I'd like to see them, secure their. And my feeling is that with the Lucas in place, if for some reason you're transporting a VFib patient, with recurring VFib on a Lucas device, and Lucas device is running, you kind of have to, it really helps to have that airway secured with an ET tube in place. So I'll grant you that. Now, when you do that, though, put your nasal cannula on when you're intubating the patient. They're apneic, so keep the nasal cannula in place while you're doing the intubation. Give yourself at least a little advantage there. Direct to video laryngoscope, we're still trying out various and sundry video laryngoscopes. You want suction of the bougie, endotracheal tube, and one size smaller. If you can't get the big one in, try the little one. Tube holder, etc., etc. If the patient has trismus, because you're doing excellent CPR usually, you can use a paralytic. You don't have to sedate them if they're unconscious and not making any movement, spontaneous movement on their own. Now, should the patient achieve ROSC or become responsive, the Multnomah County protocol says if they have CPR-induced awareness, I don't think anybody, if they look at you, that's one thing, but you know, if they start moving around, seeming to have some sort of response, go ahead and use analgesia and sedation after you intubate them. That's only nice. Okay, why do you use a long-term paralytic? If you're unable to ventilate the patient due to chest rigidity, or the patient's successfully intubated, they're not responding to maximum sedation and pain medication, then you risk losing the patent airway. I don't want to see I hate to see long-term paralytics given after you get ROSC, because we won't know for 60 minutes whether the patient's waking up or not. And what's the maximum sedation? And so I mean, they get 2 doses of fentanyl and two doses of Versed. Would that be, if they're still fighting you after that, they're probably awake under there somewhere. But then if you're worried about losing your tube, usually we're going to lose our tube if we've done inadequate sedation and pain management. And rocuronium would be your drug of choice unless you still have some of the vecuronium left that was going around. Couple notes and precautions we've added. Any patient, including trauma, that you are unable to establish or maintain an adequate airway can be diverted to the closest hospital to let the ER physician and or anesthesiologist try to help getting an airway for you. Continuing to monitor vital signs, cardiac rhythm, perfusion, etc. For suboptimal glottic visualization, remove cricoid pressure if you forgot and put it on, or do external laryngeal manipulation, change the operative position of the height of the stretcher, change the patient position, elevate the head off the bed with the intubator's hand. If glottic visualization, and use better suction, laryngoscope you can handle the laryngoscope differently, and the newer ones, the newer video ones, hyperangulated blades come in handy in certain instances. Change the blade, change the size, change the type, change the operator. Video laryngoscope. Okay. Paralytics do not affect level of consciousness. It will always be used with analgesia and sedation. Etomidate is not used in DSI. Long-term paralytic procedure is not to be used for patients in status seizures, because we won't know until it wears off whether they're still in seizure. Document, just like you always do, most important, ETCO2 and numeric value. If C-spine precautions are necessary, the patient should have manual cervical inline stabilization of the cervical collar open during laryngoscopy. C-spine precautions are not a contraindication to the correct positioning of the patient. Remember, looking at the ceiling, ear, sternal notch, 15 degrees head elevation. Okay, so this is the advanced airway flow sheet, and we try to make it very simple. It's just a reminder. So pre-oxygenation goal is 94% SaO2. And try to do that. If you do that, then you do rapid sequence induction. Standard procedure. If you can't get it, if you cannot manage to get adequate oxygenation, then ketamine is given over 60 seconds, 2 milligrams per kilo, and then either a BVM with PEEP or CPAP for 3 minutes with no assisted ventilation if they're breathing adequately. If they're not breathing adequately, then you use a BVM 2-person technique, 10 of PEEP. You can increase the PEEP if needed, and bag them to get them up. If you get them up to 94%, give the paralytic and intubate. If you can't get them to 94 or above at any point in time, then drop an SGA and ventilate. You may elect that you have to use a paralytic at that point. That's okay. Okay, not to get excited, because we will go, each paramedic in the county is going to have to go through the training sessions, but we're doing in batches. And I want fire to train with transport, because that's how you actually do your work together. I'm going to call this a team sport. Okay, any questions? Your agencies will be assigning times and all that for the training. We've got the training trainers, and this will occur in some of the training will be at fire quarters. Some of them will be at AMR, North Country and Campus. Get to do their own stuff. Okay. All right. So look forward to seeing you in practice sessions.
See you, man.